when the right time is to speak up. But just speak up, even if you accidentally do so when somebody else is talking. I'll work you in. Laura Herrera could not be with us today. She apologizes. She has another commitment, but we will keep her in the loop. And just a couple announcements. MHA is well wired for sound. There's some microphones hanging around the ceiling, so you don't have to have a microphone in front of you. That said, I've been asked to remind people to kind of talk up a little bit and project, so that particularly the folks on the phone can hear, and also our friends a little bit toward the back of the room can hear. It just helps to project a little bit. And so, Donna, any opening thoughts on your part, or should we plunge in?
Plunge in.
Plunge. Okay, we're going to plunge. I will welcome you on behalf of myself, Donna, Carmela, and Laura. That will be easy. And what we're going to, I see Carmela in the back there, so she's just walked in. What we're going to do today is begin with my colleague, Greg Bachon, in just a moment from HMA and his presentation. And Greg's going to talk about a budget for all of our investment priorities and how that's going to go, and answer questions. So he has a slide presentation. He and Deb Gracie, who's right there in the front row from HMA, and Art Jones, and all have spent a lot of time developing a budget, but particularly Greg, for not only startup costs but also operating costs. So he's going to walk you through that in just a minute. Following that, an important item of business will be to go through the draft report, which we sent out a week ago today. I know some of you have had a chance to go through it carefully. Others probably only had a chance to skim, and I understand that you're very busy. But we're going to get your comments on that and suggested revisions and improvements. And then our team is going to incorporate those. I'm going to be out of town for a couple of days for most of the rest of the week, but my colleagues are going to be working to organize and synthesize your comments. Then we will work those in and try to give you another final peek for just tweaks, not at that point, so because we have a deadline on getting this done. So the important thing is on the bigger thoughts that are not minor edits, let's get those out today so that the final peak will be just hopefully minor stuff. Welcome. And if you want to say anything before we get started?
Keep going.
Okay, great.
Thank you.
All right, great.
Thank you all for being here. We appreciate it.
Great. Well, with that, I'll turn to Greg Bachon to get us started.
Excellent. Thank you, Jack. Thank you, everyone. I was on the CARE plan panel, so introduced previously, but I thought it would be good to reintroduce myself specifically to expertise around this component. So I'm a physician in internal medicine. I'm a medical director of a care coordination entity in Illinois, and there created a budget implementation of the IT system and configuration thereof. I've worked with a number of large health systems in choosing, configuring, setting up a budget for their care management applications, and even helping systems to build one and create a budget for that. And at a state level, helping out with health homes and budgets across a larger endeavor. So with that said, though, certainly come to this with a lot of work, but being humble about it, knowing that this is the first hit at this, and we have good numbers and reasons to back these up, but it does need to be taken to the next step and get detailed specifications for the IT pieces. Okay, so we go to the the next slide, which is purpose of this particular presentation. The next slide is on purpose, if you have it there. It's essentially to develop a high-level budget that we can take a look at and say what is the cost across the state level. So we know that there's a lot of costs that are also at the local and regional level, but this is at the very highest level. This is what it takes to build a kind of scaffolding architecture around the IT piece. It was built up both from saying what are those functions that need to be at that, and you all weighed in on that and have a grid related to that. What are the functions that need to happen at a state level? And also looking from the bottom up in terms of what is the population we're covering and what is the PM that could kind of justify itself for this component, this IT component. So looking from both sides of that. The use of this, again, we know that there is planning and budgeting, et cetera, to happen at the that's going to be happening at the regional levels as well. Budgets to be defined and set, but this is for the state level. Those things that make sense and that you've identified make sense at the state level, IT and analytics. So looking at not only what are those costs, but the first funds that are identified where they can be. So let's go to the here, which really has some of the detail around the line items. At a high level, it's broken up into startup costs, which you see on the right, and operational costs on the left, so things that will be ongoing costs over time. I think the best way to kind of just digest this quick is to look at the first bullet in each one of these sides. If we look at the first bullet on each side here, we're talking about data analytics. And that's really the infrastructure, the data warehouse, the reporting tools, the risk analysis, and getting those out to the people that need them in a usable format. So on the $8.5 million, there is $1 million of technical assistance. The rest is really, and when you look at the left-hand side, you're really looking at information technology components, not the kind of HR, except for one piece. So let's go to the second bullet. So we have $8.5 million as a startup cost for the data analytic infrastructure and $3.7 million ongoing. The next is data sharing. And this is getting the data that's brought in from the hospitals, from EMRs, back out to care managers and to other people to practices to care manage the population. On the right-hand side, on the startup cost, is $2 million of technical assistance and $2 million of IT costs. And the ongoing cost is all IT, somewhere around $500,000. The next line is not IT. That is support, training. It is on the right-hand side as far as startup cost. About half of that, a little over $4 million, is to support regional infrastructure planning and startup. And as an ongoing cost, it's the HR pieces around quality assurance and improvement. So, essentially making sure that which the regions and the local structures have committed to getting done is getting done into a system with that on the care coordination side. The big cost here, which, there certainly is things to be learned as you do it across a large volume, is connecting to ambulatory EMRs and long-term care facilities. So making that IT connection that's automated interface between these, that's a large lift at first, and relatively at $1.5 million is an ongoing cost to maintain those interfaces that are created. The last one on the left is not represented on the right because it's not a startup cost. It's a PM for a care management application. So the local and regional care coordination entities will need a care management application. There may be some regions or some providers who choose not to use that, and they need a default application. So that's what this would represent. You see some of the bases here. It is assuming that we get to 80%, which is very high, of practices across the state being interfaced at long-term care facilities, and gives you a number there on the 332,000 Medicare. So, yep.
We have a question.
Yep.
In the left side of the annual operating cost, I'm just, if 8 million is low, or 3.5 times 8 million.
Yeah, 3.5x the difference.
The number of people we're trying to connect to, is it the size and scope of the network? What's the order of magnitude?
It is an uncertainty factor that this is 8 million is kind of at the low end of estimating what the cost is across the area. A chunk of that is certainly in the data analytic environment and how you decide to do that, right? Whether it's a number of best-in-class vendors that are being integrated by at kind of a state level versus a single vendor. So it changes the cost significantly on that piece. So it's definitely an uncertainty factor.
And Greg, can I ask a question? How much more detail is there underneath this? We all work with numbers, and sometimes there isn't a lot underneath this. Can you help us understand that? Should we want to move in one direction or another?
Yeah, there is more to be done. So, in terms of what the next step for someone to do would be to create specifications, and this is exactly what we want to get done. Here are the functional pieces that need to happen based on the grid, and knowing that care coordination all across the state requires certain pieces, permission management, NPI, which is already in place. But these are the components that it would take to do it, and these are the costs for each one of those components.
So there are components, but should we think of these as city the ballpark is in?
What in?
The city that the ballpark is in kind of estimates?
Yeah.
Okay.
Yeah, these are high level, yes. But they do build up in two different directions, right? Because you want to see, did you get it about in the right place? And one is in a functional approach. Okay, here are the different pieces. The other is on a PM approach.
I had a question on the goal of the 80%. Does that imply a certain level of sophistication in the EMRs, in the practices, so that might not be attainable? Because when I think of connectivity, and I'm probably the most non-technical person here, but I would assume that practices need to be at a certain level in order to be able to connect it. Otherwise, we might not reach that, correct?
Yeah, there are uncertainties there. That is part of that 31 million, and is that the right number? There's different, there was actually higher and lower estimates around that. And some of that is the depth of penetration into those practices. Are you going down to practices that would be more difficult or that have EMRs that are a single instance and you really have to do a particular interface for that practice versus there's a web-based EMR that you could figure it out once and then you have a whole bunch of practices. So it's going to change the per practice cost. Have a high variability there because of those different practices, but this is taking into account going pretty deep into the to what's out there.
And I think that's an important concept, especially when we get to the funding sources, because I think the expectation is that the practices themselves have to make an investment in order to make it work. I'm not sure.
And and I would say they certainly will and will have to. I'm not sure that it's the right place to make the investment on the IT side for this. In other words, they will need to make an investment in terms of time and energy. And, yeah.
Along the same lines, are you envisioning the practices being strictly primary care practices, or are you talking about community organizations that may be assisting with this as well? Or?
Yeah, so this is looking at the ambulatory primary care practices and the long-term care facilities. There are certainly IT systems that one could connect into in community provision of services that would be of interest. It doesn't reflect in this particular budget, though. And I think I understand your question a little bit more after you, which is that for those practices, they may need to put in actual time of their IT or their IT center. That's true. Yeah.
But I think the 4,000 covers more than just primary care, because there's that. I was thinking that was actually that number on here was covering more than just primary care.
Yes.
So it isn't just primary care practices. It could be care coordination for mental health professionals that would be picked up in that 4,000.
Yes, and it was certainly thought about as the care management.
It was thought of as the community-based providers.
Yeah.
Greg, it seems like just in terms of the HHS and ONC and the HSCRC fix that is looming here seem to all point to the fact that all of the EMRs will need to be interoperable in some way within the next 2 years time frame.
CCD
and penalties.
Yeah.
So investment could shift a little bit so that those that are ready could join in this, and those that are not yet ready are forced to be ready.
Absolutely right. Yeah, riding a little wave here that one could, lead to a lower cost potentially. So this is a pictorial of, what I'm sure we all know, but that this state-level IT infrastructure is supporting other large, enormous investments, both in the past and in the future. So, we just think about the amount of dollars that are put into EMRs. Here's a way of leveraging that past investment in those EMR solutions. But also future, and the blue one really is what would happen or will happen at the regional and local level, the care coordination processes. The chronic care management, you really need this kind of infrastructure in order to be effective in delivering that service, and other state plans.
We could add SGR fix to it now.
As a past year.
2 more weeks. Okay, and what we have here is really some of the similar information. This is the dollars that we saw on the previous slides, but just assigned to components of the grid, with what was identified as top priorities really being concentrated and mostly in that top bucket, where we see startup costs of $8.5 million, and that is building that initial data analytic infrastructure. We'll say that what we've been talking about in that blue kind of bubble, the care coordination infrastructure, which is a larger budgetary piece in the end, is in that cell that says to be determined at the regional level.
Could you comment, Greg, on the second block there, encouraging patient-centered care? Knowing nothing, the order of magnitude of that surprised me, just especially relative to the first block. Could you just talk a little bit about that?
Yeah, so $2 million of that is technical assistance. You're talking about the startup piece particularly, the 4.2? Yeah, so $2 million of that is technical assistance to help regional entities in executing on this, on encouraging that patient-centered care. The $2.2 million is really IT pieces on a patient-facing portal, on allowing them to make decisions around data sharing, messaging out to providers. So it's 2.2 of IT and $2 million of technical assistance. On the operations cost, really $1 million of that is the default care management application. So, more than half of that is something that is uncertain. How many practices or how many regions would decide that, they don't have a care management application and need something at a state level to tap into. that's a big piece of that is that part.
Can I also ask a question? Would this also be an opportunity to have patients electronically interface with certain applications, like if we could all choose the same advanced directive, the 5 wishes packet that is now a booklet, perhaps having it an interface where they can, from the comfort of their home, fill out the advanced directive and then have it placed in here. So not only is it information going out, but a way for information to come back in?
Yeah, and so the way, yes, so some of that would be the technical assistance part, right, making that happen, which one, and how to educate patients about it. So there would certainly be a piece of that. But the technical side, yes, that the kind of cost related to that care management application, envision an application that is interactive with the patient, for sure.
A couple of questions on that same slot. That doesn't anticipate any incentives for patients to do this. I quickly point to what the private payers are doing with subsidies or incentives to complete a health risk assessment, et cetera. That doesn't anticipate anything like that here.
No, but that's a good point.
If we do things like advanced directives, we need to think of that as a pretty significant lift. Chris and MHCC have been involved in a very preliminary effort. I can tell you uptake is very slow. And the electronic advanced directive registries that exist elsewhere that have been in existence for a while don't seem to get a lot of traction. So you have, I think it actually is quite hopeful for the future, but it does require quite a bit of investment. And many of the solutions really have not linked up with EHR's systems. So just where do they go? You have to pair that with an interface to a provider, preferably one in which they don't they have one-touch access to that record. In the demos we've seen, even on an electronic solution, many of the complaints were it's not easily accessible. I don't have time to click on this and go elsewhere. But I think it's definitely the big issue on advanced directives that we've learned is that you have to make a big investment on the consumer side to get uptake.
Just a reminder, because I got a reminder too, speak up a little bit, or if you don't want to be like, gosh, I'm talking about it, I can't, just ask for the mic and we'll pass it around a little bit, just so everybody can hear. Either way, but don't hesitate to sign for these. Put up your hand, we'll shoot you the mic. And Greg now has
the special mic.
Yes. So that should work a little better. Thank you.
All right, great. So this is another way of looking at the budgetary items that we looked at on a previous slide and does it per the grid. To look at some of the uncertainty that there was in the budget, again, you saw that a 3.5x differential there on the potential for an operating budget. Some of that is in this idea here, which is there are different strategies by which to build and lift up this data analytics environment. And this is a false dichotomy because it would probably fall somewhere along this line. But to think of it this way, that the choices would be to think about the functional things that needed to get done in order to lift up this data analytic environment and to get the best-in-class vendors to do those functional pieces.
You switch to the next slide, Greg.
Oh, thank you.
So you're confusing my colleague over here, I should say.
Yeah, I apologize.
No problem.
Right, next slide. Two ends of the spectrum. That's what we're talking about here. And thinking back to a previous slide where there was a 3x differential between the ongoing costs for the IT, the data analytic part. And this is one of the pieces of that uncertainty that needs to be resolved, and that is one could look at the functional pieces and solve those with individual vendors or solutions versus going and getting a single vendor that has everything completely integrated already. potentially advantages and disadvantages to each. It might be much faster to get a single vendor that has a solution already put together. You might not have as many choices about what the output is or how that gets accomplished. So our recommendation, I think the right next step, and for this group to call for, would be a expert group to look at the choices, and really what would that be? That would be more defining the specifications. Here are the functions we need, here are the specifications, really getting down to the IT details enough to be able to bid that and say, okay, how much does it cost to do these different ways, and how fast could it occur? So a group to get that accomplished. So potential revenues. Certainly there are significant revenue potential around to get started on the highest priority items. BRF is one we've been talking about and correlates reasonably well to that bucket of highest priority startup cost that we saw on the previous grid amount of $8.7 million. It would cover that and then some. And then some other sources here as well. The TCPI grant of $30 million and other potential sources to get this accomplished at the state level. Again, knowing that this is a relatively small investment compared to the previous investments in EMRs and future investments that are planned in the care coordination at regional levels. Questions on the other questions on the budget and the specific, kind of suggestion to move this to a group to define specifications?
May I ask you a question, Greg, back to two ends of the spectrum? I'm wondering, is it two ends of the spectrum or is it potentially both?
Yeah,
that is, we've been thinking about this on parallel tracks. That is, there is existing data, and how can we combine that and make use of that? And then there is the mother load of data that we are hopeful of acquiring, which sort of kicks us into a whole new level of data analytics and manipulation. And I'm wondering if, if the best in breed isn't the approach potentially for the first, but no matter what we do when we get into that larger set, if we're successful in acquiring all of that Medicare data, we are by default in the second category. I was just wondering, as you put these numbers together, what you're thinking.
Yes, I actually do think that this is not a real dichotomy to say that the most likely right answer is going to be somewhere in the middle of that spectrum, and maybe one side or the other, but a combination. I do agree with that. And to be determined, based on clearly outlining what are the functional pieces, what are the specification, what's the data that is available, and what those vendors can consume when you're talking about a potential single vendor.
The thought about the concept of a vendor, I think, is a little bit confusing here to me, because I think there is the data analytics piece of bringing in and sort of shaping the Medicare data. And then, yes, there are companies that do allow another level of developing algorithms for use, for whatever use that we might have. I think there is a tremendous amount of talent in businesses and universities in this state that to have it all be a single solution and have it all fit all is probably not a reasonable one. And so, although it's not really multiple vendors, I think that the most productive future state is likely to be a single vendor to help organize the data and then be able to innovate off of that using local talent.
process would be, for the RFP would be an RFP in multiple parts where whoever would be responding to could either choose a part or multiple parts in their response. That comes with
That could be what we're
or piece.
Yeah,
Or do it in collaboration with others.
do it in collaboration. Yeah, I think looking to a group that already is representative, CRISP, that has expertise, and having them have a expert group further define what the specifications are in a manner that could be put out to RFP in components or as a whole, but having defined that at the group level, the committee level. Yeah.
It seems just kind of a priority that there are some things here which are kind of generic data analytics, which can, any national company worth salt.
Right.
And then there's some things that are more local and require more sustainability, which would be much more applicable for some of us who think local business, local company, local university.
I agree. Yeah.
I have a question. I'm trying to understand. So when you say care coordination, are you talking about the coordination of care when the patient leaves the hospital in that transition care, and the care coordination once they leave in between, when they're between
The whole
thing? And when you talk about the IT infrastructure, are you talking about the software that you need to capture that?
No, so it does specifically cut off there that this budget and idea envisions regional and or local entities having a care management application, whether that be part of the EMR or a separate application, but that there is software application that builds on this structure and scaffolding, uses this infrastructure in which to, and those care management applications, as was said, would be part of what is interfaced with. So the information generated there is part of what is going into the larger infrastructure.
So you're saying, so these dollars are for a large integration effort that would integrate case management tools from the hospital, care management tools from a practice, and any other entity that's out there that's doing coordination of care. This is the integration of all that, plus integrating those other information systems that you're going to need in order to do the care management, which would mean like social services, etc. So this is a big enterprise-wide integration effort.
Yeah, and I would say, we could use the word integration, and that maybe is the right one, but just to know that the idea at that state level is to bring in that information and to have it organized in a way that makes it of use to others and other applications. But I think it's what you're saying.
We spend a lot of time talking about bringing common elements up into to be able to be viewed through CRISP. So a common care plan element, which is a lot different than integrating all of the things that are going on. So we talked about, I'll call it more of a light version of what we would be trying to be able to bring up a light version that we can share across providers and that we can understand what providers are serving a patient and be able to share common information so that if Mrs. Jones goes into the doctor's office that we can know that Mrs. Jones has these 5 chronic conditions and some other things. So it's at a higher, some of it is at a higher level.
Well, isn't it what you have defined in a couple of slides or before?
Yes.
It's that intersection.
Yeah.
Well,
just if I was following in terms of the comment about if we get the mother loaded data, or even if we don't get what was referred to as the mother load, and then there were comments about letting the local universities play. And for me, I guess when I think about it, I think that you got the population-based, we talk about a population-based and patient-centric model. I continue to think that the population-based aspect, it makes some sense to do together. With the predictive modeling piece, if we get that mother-loaded data, there are definitely a number of companies nationally, but I don't think there's that many that can, that can real time. And even so, it's not even about being the best. I mean, we want to be the best, but what we really want to do is be efficient. And say we've got these 800,000 people, and we want to continually focus on the ones we want to focus on. And if we are getting updates the way an ACO would get, I mean, that's real work to real time. He's cycling through this big database. So that's the piece I think it is good to pick one vendor and do it together, and then the patient-centric piece I think is where people would start to take it over.
Maybe another analogy, I don't know if it's a pyramid, but we're trying to build that base. And to say we have an opportunity in Maryland to build a data infrastructure together rather than every man for himself or woman for herself. But there is some core piece that we could put together, but then riding on top of that piece would be some of the individual organizational care management tools as an example. We're trying to say, can we build the data infrastructure? Can we collectively identify those high-risk patients? And can we continue that on an ongoing basis and basically allow everybody to benefit from that core platform, I guess is how I'm thinking.
Can you clarify the role of CRISP in the plug-and-play? Because one of the things we talked about is not replicating and trying to avoid any duplication of effort. So
we were
talking
about them as a general contractor, really, to put together a committee of experts and of stakeholders to help run the contracting process to select the vendors, but also just because of who they are and their information exchange, they will be involved ultimately in receiving and receiving information from and with a vendor potentially.
With the third bullet about using all of the investment already, I didn't know if that was referring to CRISP.
Yes. And would we with a single vendor? Yeah, I think that you would. The answer is yes. You would be able to use those prior.
But this two ends of the spectrum reflecting the spectrum necessary to do all that you have in the 5G slide. So it's not just the analytics.
Right.
You're talking about a single vendor solution so that could do the standardization of a care profile, the creation of that document,
no, this was about the data analytics, that there really wouldn't be a single vendor to do all of those components.
I think Rob,
one has argued that there could be. That's why I asked.
Okay.
So if it's just the analytics slide, it's not a big deal. I mean, you just figure it out. What's the best way to do it? T2 is through the best of breed or through a single solution, but you just get to where you get. Yeah.
Okay, interest of time, we're going to move on. You got a couple more slides.
So just for clarification, are you saying this slide, this last slide that has the 12 million, 30 million, is this for everything that you're suggesting?
These are just some potential sources to pay for everything on that yellow slide.
The 30 million TCPI grants, a lot of that's for training, so it's not, you can't use it to pay for IT.
But there are technical.
But there are training pieces involved in it, so you could use it to pay for the training pieces, some of the training pieces. But I think we've got 12 million there and some portion of TCPI, but I think there's quite a bit more money to chase down in terms of.
We like that circle.
We will be dialing for dollars. So if anybody has good places for us to dial, we'll be chasing money.
Well, and my sense is, Jack, is I think where you're taking us, we're back to the the fundamental problem we started with. There's a boatload of work to do in limited funds. So the question becomes, have we prioritized these items properly from the perspective of this group that we can point the state, the commission in the right direction, understanding that ultimately what comes out of this, we probably will never have sufficient funds, but it becomes then an ongoing work plan to come back and point to over time, understanding there's a limited amount of money available.
Yeah, I think the only thing that we really need is, for right this second, is what we need to take to the commission and say, hey, we're ready to move forward with these recommendations to put the BRFA funding in hospital rates for the rest of the fiscal year, meaning May and June. So collect the money and spend it after planning and RFPs and et cetera and so forth, and due diligence are all done, but to get the money collected and ready to spend.
Yeah, I think that's right. And the purpose of this exercise is to give you all and others an understanding of the order of magnitude of the startup costs and the ongoing costs, so that somebody doesn't say, which I would say if I didn't see this and I was an outside reader, well, thanks, wonderful wish list of investments. How are you going to pay for it? How much does it cost? How are you going to pay for it? And I think Greg was clear. At least my understanding is that this is a good approximation. There's a range. These could be thought of as point estimates around which there's a range. It could be a little higher, it could be a little lower, but it does give you an idea of the order of magnitude. And it leaves one feeling that this isn't something that you can just, buy on the cheap, and it requires a real investment. And I think that's my takeaway. Anything to add? Thank you. Any final questions for Greg? Okay, good. Oh, yes.
Timeline of it? Any sense of that? I mean, should funding magically appear and we have green light? Is that a year, 2 years?
It depends on the different components. There is a, the connection to all the ambulatory practices was not one of the top priorities, but, is a priority listed in the grid. That could, take a little longer and be more like the year, but the raising the data analytic infrastructure could be significantly less. Again, depends on the, where on the spectrum you're.
So when
some of the things are already underway, like using the existing data. Where the TRISP is already underway with that process, and of starting to think about the permissions, of which everybody said, even the just share data we already have, we need to have some more approaches and rules. So some things are, the planning process is underway. We had already provided through the CRISP budget through HSCRC some money to help that process along a little bit earlier this year. So that part of it can get on track fast, and getting the DOA going with CMS can get on track fast while the technical group gets together and gets going on vendor selection processes. So I think getting Maryland data out more quickly can happen in the near term, and while getting the Medicare data, getting the DUA processing, getting plans for getting the Medicare data will take longer.
Okay. This is a point where I want to pause and see if any of our colleagues who may be joining us by webinar would like to chime in before I'm about to transition to the report draft. But if there's anybody that has a question or comment about what we've been talking about the last half hour, please speak up. Okay, not hearing anything. Again, if you want to join in later, anytime. Thank you, Greg.
I do actually want to make one more comment to Deb. We do have the Medicare data already, and so we could actually file a DUA request, which would be a short timeline for an analytic analytic vendor to do population-based analytics. This isn't sharing individually identifiable data, but even just taking some of the tracks here that people want to get a little bit more into. What should we think about opportunities with long-term care, or what should we think about opportunities with mental health, or what should we think about? We could actually go down that road too in the very short term with an analytic vendor that CMS would approve to go into that data and produce reports that aren't at any identifiable data level. So we have additional information that could be accessed in the short term.
I think about the reason this group was convened. I mean, it's the right thing to do for the patient, obviously, but the idea to bend the cost curve and to manage these patients in connection to our agreement with CMS. So as I think about the investment and all of the heavy lifting that needs to be done, where that is for actionable, data, and then the results that we're going to see, it seems like a long road ahead of us. And I just want to make sure that it still can be connected to our agreement with CMS, and it makes sense. Otherwise, when we're prioritizing, we might want to look for some quicker hits in order to move that deal.
Right. Quicker hits are good.
Howard.
I think in keeping with that, the data is wonderful. We'll live by data, and the analytics will really be helpful. But unless there's something you can do with that data, it's just data. The quicker hits are all at the level of the application. And I think for that reason, it's important to not let the applications to whoever, the primary care or the care coordinator, whoever it is, lift all of that today. Otherwise, you wind up with a heavy lift for a lot of data without everything being shown for it. History it shows that the roadside is littered with lots of dead data analytic programs that couldn't really bring anything to anybody. So getting the applications right has to be part of that process to begin with.
Good. Thank you. Okay. Thanks again, Greg. We're now going to transition into, and if somebody could help me get the report on the screen, that would be helpful. And to discuss the draft report, I thought the way I would organize this, if it's okay with you, is to start with general reactions. We will allow plenty of time for specific concerns. Thanks. And with the magic of the remote, I can turn to the page when we get to specifics that interest you. But before we do specifics, are there any overall thoughts like, gee, Jack, I read and read and read and kept waiting to see something on X, and I didn't see it, and I think X is important. Or I'm concerned about the tone of this section, or it just doesn't seem right, or you need to reframe this argument or something. It didn't quite convince me. Those kind of things, or hopefully it's objective and so on. But any overarching comments about how the draft struck you that are in order now?
Everyone was wide awake reading everything.
Yes, I know. This is good bedtime reading, Debbie.
I can start.
Okay, thank you.
I was surprised I didn't see something in here, maybe I missed it, about the need to recognize the investments that are currently in play and avoiding duplication of effort. Because I think I've shared with this group before, my organization has invested a lot in a lot of different things that we're talking about. So I think that needs to be acknowledged because there's a lot of good things happening in the industry.
Well, thank you for that comment. I have prepared, along with a colleague at HMA, Jessica Foster, in our DC office, a paper that in due time will find its way to you, hopefully soon, on just that subject. And in fact, both giving us examples of promising initiatives in their field of expertise. And Mosaic and Waystation and a number of others that hold promise. We looked at some hospital initiatives like the J-CHIP program at Johns Hopkins and activities at Western Maryland. That and Frederick. So there's some hospital initiatives noted, some payer initiatives on the PCMH side, both the state sponsored pilot project that's been going on the last few years and the Care First model and so on. So we have that together. I do think it's important. It's under review, and it was too long really to incorporate in a as a type report. Maybe it could be an appendix or a supplementary material, but we will get it to you.
So even in the setting of the stage, though, in the executive summary,
Yeah.
I think that one bullet on the fact that.
Yeah, we spent a lot of time talking about that in this group, and so what I hear you saying is, hey, when we were coming up with these recommendations, we came up with them specifically to avoid duplicating investments that were already there. So the reason that we came up with a profile instead of a standard care management application for everybody is because we have investments that are already being made. So acknowledging up front that it was done in the light of that, and part of the reason that we're doing this is to continue to avoid duplication of resources at the community level as well. So we want to avoid duplication, and also the recommendation is based on investments that are already there.
Yeah. Oh, thank you. And maybe we can then say, for example, a brief set of examples drawn from this long paper. I agree with you that needs to be there. You didn't miss it. It's not there. And drawing on the longer paper, I'll try to weave in.
The $2 billion that's already been invested in EMRs in the state, for example.
I think this is a point that we've got to finalize, because this has been a point of confusion throughout the discussion. And I agree with Donna just said, is that we have had that discussion. And that where we ended up was, I think you called it 20 minutes ago or so, Care Plan Life or Care Something Life. Where I think we ended up was that there is an opportunity at the state level to create an environment that will support acceleration of care coordination, knowing that there's a lot of things going on already that are trying to do that. And that level of acceleration is related to data. That it's related first to data and connectivity to data, so people can actually get the data, and then some additional information that can be shared through health information exchange, the care profile. But the complexity of the work that we've been struggling with here perhaps won't be understood by another reader. They're not going to understand that we went through that.
So we need to tell them that we did,
Yeah.
and that this is really not about creating the end-all at the state level. This is about optimizing the assets that have already been invested in, and
Building on what exists.
building on the big investments that have already been made.
I mean, you almost have to say, this is what if we're successful in this, we'll have this, but we won't have this. Just defining it a little bit more. Because I am concerned that some person who hasn't been sitting here will be confused. Even the term care profile. We now understand it, but no one else will.
And if I may, I'm really a fan of this picture. At least it works for me, and maybe we actually consider putting it in the text. That is, what we're saying is we're not going to do everything for everyone. What we're saying is there's some core intersection of this care coordination work, in your words, Patty, that would be accelerated. It's the data piece that would be accelerated by these investments. But each of these sort of other pieces has to develop on its own. So what we've done is to try to say, what's that core piece that will lift all efforts? But it's not everything for everybody.
I just want to say, I don't disagree with anything you all said. I'm with you, but for my docs, some of them are not as advanced as you are on this. So we need to make sure that we might need to go down into the propeller of the little picture there for us a little more than for the rest of you guys. So just taking into consideration that a lot of ambulatory practices particularly don't have the infrastructure in place, particularly around care management, that the hospitals and the insurers and others have put in place. And I think that's also true for some of the other community providers that aren't necessarily here, like the FQHCs and the other folks like that might not have as much. So we just need to be flexible and remember them as we integrate them in. Does that make sense? You're looking confused there.
No, I was just marveling because I had nicknamed that the butterfly chart, but the propeller chart may be a better description.
Butterflies only have 2 wings, though.
Yeah, I know. See, that's one. I need to stick to facility. Yeah. Propeller it is. Okay. All those points. Thank you. Very well taken. We need to sharpen that up. Ernest.
One good point. It's a little bit, it's more dynamic than I guess what I'm trying to get to is that, what we're looking at, and we want to get the most bang for our buck, are those high-risk patients who cost the most to the hospital. Those high-risk patients' care coordination is much more complicated than as you go around the spectrum. So the systems that you have to create for the high-risk patients are going to cost a lot more than a generic system that you do. And I just want you to know that. And if you're going to get bang for the buck, you're going to have to build a system that's going to take care of the high-risk people. Or you're going to have a system that's sort of in the middle of the road, and the high-risk people won't be taken care of. So the high-risk people are very difficult to care coordinate, and the technology you need, even if you don't have it. So one of the things I'm concerned about is that where's the money for okay, here's the technology, you need that. But where are the people who are doing the care coordinating? How do they cost? And how is that then? They need startup money before you can get to, it's just like starting a practice. If you're going to start a care coordination practice for high-risk people, I'm telling you because I'm doing it. You got to have people who can manage that, and you're going to need some startup money. Most people don't have that. I mean, when you're trying to start that up. And then there, I'm sure there are ways to get ultimately get it paid for. But I think I just want to be sure that that cost is covered, and the cost that it's going to take to use other, entities. You got to pay for other services that you've got to pull in there to take care of those people.
Outside the medical model.
Outside the medical model.
Right.
That's my biggest concern, because it's a cost. And whether you use the IT is a cost, and we need that. But even the IT systems that got to be used for those high-risk patients is a costly IT system. It's not just pulling the electronic medical records together and exchanging information. It's not just sharing a common set of information. It's a lot more information you have to share in order to make sure that that community health worker knows that this person has to show up to this social worker's office at this time, and they did it, and they got these services, and those services, all these things happen. And, when you're faced with that, I just want to say that those are the patients we got to manage. I mean, if we want to show the biggest thing for our buck. And it's not hard to figure out who they are. That hospital will tell you, these are our patients who are coming back all the time. These are people who are overutilized in the emergency room. So we don't need a lot of analytics to figure that out. What we need to help to coordinate. We need the money to coordinate those folks. That makes sense?
Yeah.
It does, and maybe I can jump in, because I think this is the frustration of this effort that we're engaged in. You're absolutely right. All of that cost. Right now, that cost is largely buried within the hospital organizations who are investing in care managers, care coordinators on top of what we're talking about here. Then we've got the physician's office and practice costs that will be in addition to what we're talking about here. So we've really carved off a small piece of what is an enormous expenditure, I think you're right.
No, the point I'm really trying to make, I guess I'm not explaining it, is that the hospital care coordination is well contained within the hospital. It doesn't coordinate that patient when they're outside. There's not a handshake. You have to shake hands with some entity down here that's coordinating that.
Well,
whether it's an ACO or whether, and when you're in a public health system, it's whatever we create to do that. But the hospital system will not coordinate that patient's care.
And so
it doesn't do it right now. Those patients that we get from dimensions or doctors or whoever, those patients, once their case manager is finished with it, they go out. And the case management says, you need to do X, Y, and Z, but who followed up to make sure they did X, Y, and Z, to make sure they get to the appointment? It falls off. There's a trailing off. It's not there's another coordination effort that has to occur. And that's what I'm concerned about. That if we don't fund that, then we won't coordinate those people's care.
And you're absolutely right, Dr. Carter, but that it's not true that there are some places that are actually doing community-based care coordination. So Western Maryland Health System, some of the TPR hospitals are already doing community-based care coordination, and MedStar is already doing fantastic coordination with nursing homes, fantastic work, and so there are already things that are going on, and people have come to the table and said, don't duplicate what we're already doing. So we've said, okay, we need to do planning on a regional and local level to figure out how to do care coordination in each locality based on what's already going on and the best approach for a locale. And that's what we're trying to do with this, to get the conversation going with DHMH and HSCRC, asking for the regions to put together applications for planning money to start that planning process. And part of the output of that process would hopefully be a budget and a sustainability plan of how are you going to fund this. Because it is, you're right, the dollars there are much larger than the dollars that we're talking about in this budget. But the planning activities haven't taken place for the most part yet. Some places have. Western Maryland's been doing it for a while, but other places haven't even started planning or are just starting planning activities. So we need that process to come into place without constraining people who are already ahead with we can't do it on a statewide basis. That's what we've concluded, is it needs to be done regionally and locally. But it is, we recognize it's a large investment.
So would an example, Ernest, be something like the following? A social worker or some kind of care manager visits the home of an elderly patient with a lot of issues, finds out that the patient is a fall risk, the electricity is going to be turned off in 3 days, they've gotten their final notice, this person is malnourished, doesn't have enough food, and the Meals on Wheels doesn't have any money left for them. They're in a queue, et cetera, which is not uncommon to find a cluster like that, from what I'm told. You would know better than I do. And I infer from what you're saying is, all right, so they find that, but that takes some money to fix. It's not just the finding, that the community may be under-resourced, or they need a crisis intervention if they have a SMI, and there isn't a slot, or they need residential treatment for substance abuse, and there isn't a slot. And so I sense that what you're saying is that there's a need for some money to address some of these factors, not just the money to build the data infrastructure. Maybe that's beyond the scope of what we can do here, but I want to see if I'm understanding.
But I guess what I think there's a need for something like a public health managed services organization that coordinates care for certain regions. Other regions may be sufficient enough to do it, but we're going to have some regions in our state that's going to need public health to do care coordination. It's going to overwhelm doctors. The hospital's not going to be able to do it. And you're going to need an entity to help with care coordination. That's what I think.
Yeah.
And that's because that's what I'm observing. And I do think there are very well from the hospital situation. But you're going to come into some areas in Maryland where that's just not going to happen with. And the state needs to have, I believe, some entity that helps with that can offset the cost of that. Because people who may be doing care coordination up here, the cost might not be the same as the cost to take. We have these extremely difficult patients. You understand?
Yep.
But their care coordination still can be done. I mean, we have resources. The interesting thing is public health departments and different CBOs, there are resources, but because their care isn't coordinated, they don't get to the resources. They're back and they use the hospital as the resource. So we got people who go to the hospital just to get something to eat, call it EMS. I can't. I can tell you multiple stories where all we have to do is tell them instead of doing that, you could do this. That would save a hospital admission. But that kind of care coordination, nobody does that. I mean, so the EMS people just say, yeah, this is happening, and that it falls on whatever it is, because nobody is focused on. There's no entity that says we need to coordinate this guy's care because he's living in Dimensions Hospital system, and he is.
So, Dr. Carter, I'm hoping that you're filing a regional application and that you'll begin to address that in the regional planning process. But I think the point would be just acknowledging up front, like we acknowledged that a lot of conversation was around not duplicating resources, is acknowledging up front that there's a lot of planning that has to be done in a regional and local basis, and the budget for that will be even bigger. You know, just making it clear that there's other resources.
I know.
You know, I did. Actually, I have.
Yes, Lori.
I would hope that that this whole entity, the notion of having data collection at the state level, would also be to provide a feedback loop as to what is working and what is not. And that may be in here, but I think to kind of respond to your concerns that, thank you, that we have found in our chronic health home that it's not the same people who are always at the top of the ladder in terms of at risk and the high utilizers. It changes. So as you do your intervention, those people come down off the top and other people come up on the top. And then you're starting to look at what is it, why are we not getting to these individuals who are constantly coming up to the top? You keep seeing these same people. Well, it may be things that right now don't exist. So we know, for instance, in behavioral health, the inability to do in-reach into hospitals is a problem because once they leave the hospital, they're gone. Trying to find them is an enormous amount of time and challenge. So we know by doing that, we would be able to catch a lot of these people who keep popping up to the top. So I'm hoping that part of what the state's role can be, or the Uber manager, whoever it is to look at those individuals who keep popping up to the top so that we can figure our interventions out in a different way and look at things in a different way. And it may not be so much a regional approach. It may be something that's a statewide issue or something that's not allowed under current billing mechanisms or for whatever reason is not common practice.
Thank you. Good point. Tori and then Howard.
I think that the report calls out pretty well. You started 830,000 Medicare beneficiaries, and we talked about the 280,000 and the 40,000. So I think we're really, clearly spelled out the top priority being those 40,000 patients. I guess a question that I have, and I was going back and forth with this chart that's listed in the report as Table 1, and it may just be optics around this, but we list in A through E, we call out what are top priorities and bold certain things. And for a couple of sections, in particular C and E, nothing under C or E is a top priority, or at least as we've used our folding, if you will. So encourage patient engagement and connecting providers are not top priorities. Yeah, we just heard the opening presentation of millions and millions of dollars of connecting providers. So I don't know if we see that as sort of a secondary. I'm just, a little bit of the optics around the table we might just want to revisit, because we say it's a top priority, and it's not necessarily sequential. We're trying to do a lot of things at the same time, but we didn't call anything in Section E a top priority, yet we called
Yeah, I guess
areas. I'm trying. I know
I
the process we went through in kind of grading this grid at 2 prior meetings, but
I kind of heard that all of these are top priorities, but then what we were really focused on is identifying things that could be BRFA funded, and maybe that's a confusing aspect of how it, maybe a clarification so that we're not, we shouldn't be saying that it's not a top priority to connect providers. I mean, I don't think we really want to say that. So we just need to say priority for BRFA funding or something so that it's not everything on here is top priority or it didn't get here from what I was hearing.
Yeah, that's
let me just see how it reads again. There's
Yeah.
all that went on within this meeting over the course of the past few months, and then there's goes to other audiences. It may just be the way it reads.
We'll take a look at that.
That's a good point, though. It could read to somebody that it's not a top priority to
Yeah.
connect providers, and we wouldn't want that to be the
I think
message at all.
4,000.
Yeah, we'll take another look at that, Tori. I see what you mean. It kind of jumps out that there's nothing in those 2 buckets. Thank you. Alan.
So I think sort of the top priority to me is to provide resources for effort to design patient care profiles and make them readily visible, doable, and viewable across the continuum. I think they kind of say the same thing. And I think just go back to what is the job that we have to do here. It seems like a care coordination infrastructure, and that's just about, in my mind, it's about communication. There's lots of information out there. It's just not being communicated across the continuum. And it seems like there was this historical thing that happened right in this area back in 1848, where Samuel Morris was busy painting, busy painting the 9 times view of the House of Representatives, and he got a letter that his wife was doing poorly back in Connecticut. At the time he returned there, she'd already been dead because the post took so long to get there. He returned to Washington, D.C. and got a grant for $10,000 from the government and set up a telegraph from D.C. to Baltimore and tapped out what God had wrought message. It was about his frustration with not being able to communicate across the continuum without great delay and difficulty because of that tragic loss of not being able to life this time. And that's, I think, where we are here in some ways. I mean, it's tragic that we have all this information and we're just not able to communicate it across the continuum with any kind of facility. And I think if we just can get to the point where we're saying that's what we want to do, to start out with, just make sure we have something that's standard to be communicated across the continuum. Get rid of the frustrations that all of us have around the table with this kind of lack of interoperability. I think we do that and nothing else, we keep killing the Morris family.
You always have the best historical stories, and I appreciate it.
Remember, this is my childhood.
Not that, but I did read the John Meacham biography of Jefferson, and that kept happening with Jefferson and his family. These horrible delays in getting home from emergencies of a week, 2 weeks.
I completely agree with what Howard said, although it reminds me of sort of what I said last time I spoke, which was, to me, that's sort of in some ways, the patient-centered piece of sharing that data, and then on top of that, the population-based piece of really just getting the data, organizing it together, predictive modeling, gaps in care campaigns, being able to, in a population-based way, prioritize who you're going to go after, document what the problems are, point people in the right direction, and then make it available to people, to the patient-centric piece when they want to address it. So I think they're equal to me. They're equally important.
And I wonder if we might not pick up on that for the setup that gets to a number of issues that have been raised. I think the point that Rob just made, there are pieces of this that can be accelerated by working together and by applying some money. There are pieces of this that don't require any money at all. I think of the last 2 years of the work we've done to create cross-care continuum teams throughout the state, and that was pulling together nursing home leaders and home health leaders and Meals on Wheels and on all the rest in communities. Sometimes that costs lunch, but it was about creating the partnerships and the relationships. And it might be helpful to think about, do we set that stage so that people understand we're not forgetting the communication and all the rest that needs to happen, but we are focusing on a place where funding sort of a collaborative infrastructure could be really helpful. I think it's
Right. And Adrian.
Well, I'm wondering if maybe, I missed this because I was up late trying to reread, but if maybe we shouldn't give some attention to the kind of the regional, the regional planning process or something maybe staff has kind of addressed, Dr. Carter is saying, but also, one of the things that I think is important, certainly in like the urban areas, maybe not quite as important in Western Maryland since there's not as many, but is patient attribution, the idea that we are to avoid duplication of efforts and to avoid patients having multiple care coordination efforts that are happening to them because they happen to go to multiple urban ERs, I think is really important. And so maybe that's outside the scope of this group, but I would think that in the regional, as these regional planning things kick off, that really there needs to be some focus on the collaboration in the region so that patients aren't getting duplication of effort and just being more confused.
Well, I'm glad the last couple speakers have brought that up because I gingerly asked this question that has been on my mind for a while and was also raised. I just want to acknowledge that our colleague Joanne Lynn couldn't be here today, but she sent a lot of thoughtful comments just yesterday to me, which I've been working my way through. And one of them is along the lines that I'm about to play out. And we have had some careful discussion over wording with the grid over the last couple of meetings. So I don't want to get this wrong. I want to capture your thinking. And that is, there was a consensus among the group that the data we collect would be used for care profiles, and we talked about that very specifically. Joanne has reminded me, and I've been thinking about this too, and this may have to do with the difference between statewide activities, which form those profiles with common formatting so that they, are comparable. But, she has reminded me that ultimately, and this may be as it percolates down to the regional and local level, we do need plans of care for individual patients, short-term and longer-term. Short-term of how to get over the crisis or illness that they're in at the moment is a plan of care, but longer-term if they are wrestling with, say, a cognitive impairment or ESRD or a whole number of problems that require a plan of care that isn't just episode-based. Yes, Greg, you may want to chime in. Yeah,
Care plan, we might call it.
A care plan. And so I'm thinking, but I want to, because I know, particularly when I listened to the transcript of our last meeting, one thing that came through loud and clear when you spend 3 hours listening to this, and it really helped me, by the way, because I can't capture all this stuff. I know it was. Yeah, I didn't do it 3 times.
You have to thank him.
Right? That's all right. I have to credit Donna for suggesting it to me, and she was right. That, you made it clear that we're talking about care profiles. Would it be right, would you be comfortable with me as I do some redrafting here and tighten this up and capture your thoughts of making this kind of distinction? I see some heads nodding, or am I off base? And if so, because Joanne's several comments in the margin was prompting me, don't forget about the care plans. I see where you're going with the care profiles. And those are helpful for kind of public goods, as we call them, that can be shared and so on. But at the end of the day, you have an individual who needs a plan.
May I jump in with some thoughts?
I'm asking for guidance.
I did not go back and listen to 3 hours worth of tape. But as I recall that conversation, it goes back to Debbie's point that was the place where we began to run into the potential for duplication. That is, that there are organizations who have already developed a care plan that is unique to their organization. And it's where we kind of lifted the concept a little bit to say a care profile could be critical basic elements that could be shared. But moving to I'll use a difficult word, dictate a particular care plan is where we may duplicate efforts that are already underway. As I listen to Joanne, it's back to this broader, there is so much that can and should be done around care coordination, and we're really only carving out a piece to say where can we apply money, again, to kind of accelerate through infrastructure. And so as I'm listening, it's, how do we not lose, of course we have to focus on care plans and care coordination and hiring care managers and all of the, and communication and everything else, but that the work of this group was very focused on some available funding and how do we best apply that.
Yep,
that's just my recollection.
Fozzie and then Rob.
So I think one of the important things is taking the concept of all the work that a lot of our organizations are already doing. And I think one of the frustrating things and one of the solutions that I'm trying to get out of this that I think would be very helpful is a care plan is only as good as the people who see it. And so we have invested a lot of time and energy into putting those care plans together. But if the right people don't have access to it at the right time, when the patient is showing up in their emergency room or in their clinic or whatever, it's worthless. And I think that's what we're trying to say is all of our organizations, many of our organizations already have those basic foundations, but how do we link all of us together so wherever the person goes throughout the state, they'll get the benefit of the work that was already done for them.
Well, and you kind of have it here. When you say lifting up out of a care plan the care profile and making it available at every point of service. And then to the extent that you can identify folks that are that actually are in inactive care management with active care plans, that we would be able to figure out a way to know that.
Right.
At which point then that's additional piece of information that your care profile will tell you, and then there's the transition back.
Right.
I think you say that here somewhere.
Yeah.
But I would agree with Carmela. I think, again, because of the complexity of this discussion, having that laid out, those distinctions that we did draw for these reasons. And it's not just the providers that are working, it's the payers. There's a huge investment on the payer side. And I don't think we want to alienate all that right now. We're not prepared to do that. We just want to begin the process of, as you say, moving information so that we can. So I do think you have to make those distinctions up front.
Okay. That's helpful. Thank you. Other comments?
And may I just make one other point? Those of us that have been involved in care management for many years know, just having a care plan doesn't mean you have an active care management situation.
Right.
I mean, there's a lot of, yeah, so I mean, there's just so much, again, complexity in the work to get to the goal. And so I think, if, we just need to do what we can do and not worry about, we can worry about it, but there's a lot of effort going on to try to figuring out what that panacea solution does look like.
And that leads me, thank you, that leads me to a related question. Again, I'm just seeking guidance here, which is the distinction between having a person designated as a care manager, who might be a nurse, might be a social worker, might be a community health worker, might be an NP, depending on the organization. Mrs. Smith is a care manager, okay, versus, and she is going to be in charge of the care management, and that's her job, versus, or hopefully these would maybe be complementary, not mutually exclusive, kind of integrating care coordination into the workflow so that the providers themselves are coordinating and are practicing medicine differently with more coordination. That seems to be important too. I don't view these as mutually exclusive, but from listening to the discussion, I'm wondering if we've jumped to thinking about care managers, you're in charge, start your engines. And many times that's the right thing, but that we're also kind of redesigning the way providers work together. Nancy, I think you You're shaking your head.
Well, I was just going to say, I think it's more about the infrastructure than one specific role. My simplistic view of the work of this group was to organize our thinking statewide around the management of the data, how we might best communicate basic information about the patients we all care for, understanding there are unique attributes and negatives in each community, but that we somehow form an infrastructure from which we can all operate in an easier way.
Okay, thanks. Rob, and then back to Fonzie.
Sure. I agreed with what you said and sort of Patty's layout of where we were together and then where we may be separate from the actual care plans. I actually thought of something that I think is relatively analogous. I don't know how many of you were familiar years ago with Medicare health support. And it's funny now that I never thought about it exactly this way, but this was where CMS, who had the data for all 45 million Medicare beneficiaries, spun the data, identified 7 million at-risk beneficiaries, 1 million COPD, 6 million diabetes. Then they respun it, looked at risk scores, picked off 3 million with diabetes that were the most at risk. Said, okay, now we got these 4 million people. Now we're going to, then they went to Social Security. They got, addresses, phone numbers. They used government data to piece it all together. And then they hired 10 vendors, and then they sort of parsed it out. And they built these beneficiary education materials that we could all had some common elements. And, and then they turned it over to us, the 10 vendors they hired around the country, to implement the care plans. Now, I could think that they're actually that in Medicare health support, there could have been, even a couple more things where it could have held together. They could have drilled further down into the data. But it's actually, I think now I'm thinking about it, it's pretty analogous to that which we can do together and the point at which you
Where did consent come into that? Or did it? At some point, do you recall?
Yeah,
that's touched on in the report.
it was opt-in. It was opt-in. So but the beneficiary, I think that was it opt-out? Yeah, opt-out. They participated, but
And what became of this?
the government actually shut it down. For all the vendors.
I'm not feeling so good now.
No, it was very good. The government just before its time, they were short-sighted. I think it was caught up in Republican Democratic politics, but it was. But the general effort I thought made a lot of sense and was reasonably analogous.
Can I change topic a little bit?
Sure.
So I might have missed it. I saw the care management code was in there. Maybe that's a little bit of this, but what's the game plan on sustainability of all this? So we go and we tell them to invest all this money, and we build all this stuff, and then how do we keep it running? And I thought we talked a little bit about that, but we've never really, it's not mentioned here. At a minimum, should we at least say that we need to make a high priority developing a sustainability plan, because it's not reasonable to expect the hospitals and other practitioners to just pay for all this stuff on an ongoing basis as the money goes away. And a lot of those funding sources you went through at the beginning were all one-time funds.
Well, there is ROI.
Right,
on the high-cost
right,
patients,
right.
We would expect an ROI of about 2 to 1 on investment. So over time, we would expect an ROI from high-cost patients. I think the hospitals, when I say we as the hospital should expect to create an ROI from their investments.
Well, I certainly think the doctors have the opportunity with the care management codes to also have return on their investment too. But I do think it's something that we need to think about and talk about, because you get your return on your investment for making people healthy, and it's kind of like one of those deals where at some point in time it gets harder and harder to make money on it. But you want to keep the infrastructure in place. You see what I'm saying? Am I making sense?
I think you make a really good point, even if it's just to raise it,
People
especially when we're talking about money. So we've got sort of this first-year number, and I think it's just this acknowledgement, because I think we're probably all here, that's not it. That's not the end of the road. And so we're going to have to figure out some way. ROI may be a piece of it. This discussion gets much more interesting if we talk about redistributing ROI. But we ought to have, I think we ought to flag it.
Well, and it's not clear to me. I understand that conceptually ROI, but who gets the ROI?
Right.
Yeah.
Right.
That's just not clear enough.
How the hospitals who are here, how active are you guys in going after these new care management codes? Is that something you're like in the process of planning for? I mean, a lot of you guys now have employed physicians. Well, I'm talking about just in the practices you guys operate or control, or is that something you're actively doing, not doing? Is it, are some of you more further along on what's going on?
There's a lot. It's a complicated process.
Well, it's also a hard discussion to have for the ones that don't have co-insurance because you're asking them to pay out of pocket. I'm just curious what you're doing, if anything, because my members, it's something we're trying to get them to do, but they're not, you know, regardless of whether they work for you or whether they're independent. I mean, it's not, there doesn't seem to be a lot of uptake, and I don't understand why, because I look at it, before I went to law school as an economics major, I look at it and I'm like, this seems like it could be a lot of money. I'm not understanding why people aren't doing it.
It's confusion, but I also think that when you look at the codes, you know, we talked about one code, and if just one code is being advertised, there is actually a suite of about a half dozen codes or more, and when you look at private payers, there's even more confusion on if you sell the whole suite of codes that are related to non-face-to-face visits. Care coordination can be much more attractive than going around saying you have one code, because I think that then engineers some practice transformation around trying to do this in a different way, whereas maybe one code by itself may not be quite as attractive.
Gene, if I could just jump in there, I think you will, the answer to the line that physicians don't jump on these non-face-to-face codes, because we have been for so long so dependent on the face-to-face volume-based care, and still right now in 2015, 90% of the revenues we get are face-to-face. It's just hard for people to wrap their minds around making that change. But the change, I think, is inevitable. I think it's going to happen.
Well, that's kind of why I asked the question about the doctors, the hospitals, and the doctors who were either connected through relationships or employed by, because you would think that they, or they would be in a different setting. You know what I mean? That in my mind, they would be the ones who would have more of an economic incentive to do it quickly or first.
You would think.
That would be the logic of it if you think about it, but it doesn't seem like anyone's moving. I understand if you have someone who is in the old school private practice, why they would have difficulty adjusting. That's logical to me. I can get that. If they haven't changed their mindset.
Not an employee position.
Well, you would think, but I don't know. I'm just curious as to why. It seems to me that's a big part of what we need to do.
Not true.
It just is interesting to me that more people aren't jumping all over these things. But anyway.
I mean, we've done it and look at it and so forth, but it's a lot harder to mandate than
We have to give them an easier on.
That is the key. We have to make it easy, or start in a community that makes the most sense to do it first, and then it'll expand once they have some success. Yeah. Anyway, but we should just say that we need to talk about. I don't think you need to write out what our plan is.
You don't just wave them
Just say we need to identify what the plan is. That seems to be something we need to work on as we go forward. It was my only point.
Yeah.
Which I think we've talked about.
Yeah, that's a fair point, Ben.
So I think Debbie raised this, I guess Adrian's not. But I think there is this, you touch on consent several times throughout, but given sort of, we probably need to think about what CMS is going to really want, and beginning to think about this as something that we're thinking through. It would be helpful, I think, to put in one section that's sort of just a short section on this being important. I think being left alone is something that CMS, Medicare does think is important for the beneficiaries to have that option. And laying that out as these documents always percolate through and will yield hopefully a trove of data in the long run, recognizing that's a sensitive issue. The other point I would make is that having seen the challenges of running a care coordination modules through PCMH, I think 1,000 flowers blooming is still where we are in terms of the model. So what everyone has said about flexibility in the data has to support multiple care management models. It's really important. We don't have, and Kim Colburn is not here today, and Laura's not going to advocate for it. We don't really have a perfect model here, and the data has to, that support it has to support multiple implementations. Really, it's going to be important. We observe that, and certainly from the PCMH model, the data limitations of not having something as Care First did in their model was a major limitation on the part of practices going forward. So I think that's clearly an investment that needs to be made. It's going to be workable.
You mean multiple approaches to care management, which would include who delivers the service?
Yeah, the idea that
it doesn't have to be a nurse. I think you were getting at.
Yeah, it doesn't. Is the work segmented a part of someone's workflow, or is it a full-time care manager?
Well, yeah, that's what I was teeing up
That's
earlier.
what you raised. I think those are key. You want to have that flexibility depending on what's happening in the community and what can be done in Western Maryland as opposed to.
Some organizations have clearly distinguished and defined a care manager from a care coordinator, different roles, different skill sets, just as an example, but it is, I think you're right, local.
And I kind of piggyback on that, because something that you had said before, and to Adrian's point, so I think one of the other big challenges is in a lot of our organizations, we have our dedicated point of contact, whether it's a social worker, case manager, one of the clinical nurses who works with oncologists. So we have someone who is investing a lot of time and effort on taking care of these patients. But when they're outside of our global system, no one even knows that they exist. So then they may go to a different hospital, and the case manager, social worker, and that was Adrian's point, then they start reinventing the wheel. And I think part of the, again, we've all built our own individual care plans and teams. Part of this work is how do you share with everyone else who's on first? How do we share that information that wherever the patient goes throughout the system, we know that Ms. Smith is their one and only point of contact, so we don't waste duplicate resources on one person and zero resources on another.
That was my, I tried to see if somebody said that's exactly that's what we run against. And that's why we need something outside of each one of those little different entities that will coordinate that. Otherwise, you don't get the handshake, and that's exactly what happens.
What bubbles out of this, does this person, in their profile, do they have a care plan, yes or no? Do they have someone watching out for them, whether it's a social worker or whoever? And if so, just have those contacts. And that way, everything gets pointed back to that person.
And I think that goes back. We did have some conversation about a valuable role for CRISP, and that is alerting. And so whether it's actually, I might even argue that it has to be back to the single person, but you're trying to alert different people who touch the same patient about what's there. And for some, it might all be there. For some, half of it may be there. But having those different care providers, I think especially in the behavioral health side of things, it may not be, sending them back to, to somebody. It may just be coordinating then those two individuals.
I mean, that's critical to patient-centered care, because especially in behavioral health, a lot of our folks have someone that they have a relationship with and that they are comfortable having those conversations with. And the idea that you're going to have another social worker, another community health worker ask you the same questions over and over again is, yeah, I mean, it's not only confusing, but it's frustrating to people, and it makes them not necessarily want to engage the system. So patient-centered care is about being able to respect somebody's wishes of, this is the person that I have a relationship with, this is the person that I trust to help me make sure that I get to my appointments and that I'm taking the right medications, and I don't want to have to, nor should I have to deal with 6 other people who also want to manage my care. Because I happen to be taken to this hospital by this crisis team or this hospital by this ambulance. And it also helps coordinate to work around someone who maybe they are shopping around, especially in behavioral health, get them back on the right track. And so, those narcotics contracts and everyone is working together to improve that.
Okay. Carmela.
I have 4. I was waiting for the end. I have 4
Is this
thoughts.
a chairman's mark?
Yeah.
You haven't had one. You haven't used up any of your
I haven't
marks.
had my sandwich yet. I'm about to pass out. 2 that I've, full disclosure, that I've already shared with Jack, and the 2 additional thoughts. Yeah. Probably does have a toy, a prize inside. First, a thought around tone. You had used that word before. I think there are a couple of places in the report where I thought we could move from negative to positive, where we've described the really bad things that happen in the system because it's so piecemeal, and I wonder if we couldn't flip that, not to be Pollyannish about it, but to be more welcoming to everybody reading the report to say, care would be much better if, we sort of did these things. The second thought, and it goes maybe to some of Joanne's thoughts, there are places where I wonder if we could source some of the literature that exists around care coordination, where we're making some broad statements about what care coordination should do or must do, or these are key components. And at least I feel like I'm skating on some thin ice there. It might be helpful to the extent we can go back and just source some of the literature. And I actually, in some places, we may have just kind of made it up ourselves. But then maybe we need to label that based on discussions of the group. I have a third thought as I was listening today, and that is, especially as we think about using BRCA funds, some of the funding mechanism we're going to be doing here will have the impact of increasing hospital rates. And as I think about that, I wonder to what extent we want to make certain that the payer community is supportive of this. That is, we're talking about making infrastructure investments for the good of the waiver, and doing that is going to raise hospital rates. And how do we make certain, I just wonder if it's worth some acknowledgement that we think this is important, and we're not out to sort of, willy-nilly raise hospital rates, but that becomes an important source of revenue using these BRCA funds. My final, and then I'll be quiet.
So let's see if I understand this right. I don't mean to interrupt you, but I want to capture it. So you'd be saying to payers, bear with us here. There are things we're going to do that in the immediate impact is going to be to raise your cost. Over to Donna's point. But we believe there's a positive ROI here. May not happen overnight, will not happen overnight, but by better managing the highest needs people, you're going to benefit from this. But that's not going to be the first thing you're going to see.
And
right?
Yes, and maybe even make the connection. I don't know that it actually does ultimately raise their prices if, in fact, we have a cap on hospital spending overall.
Yes.
But I think there has been some conversation about aspects of this that and the more people we are able to keep out of the hospital, the more it costs per individual left in the hospital. And I think it's just just some acknowledgement that we understand the impact of spending $15 million worth of BRCA funds or increasing virulent hospital rates by $15 million. But we think this is a good and useful approach. And my last thought, and it falls in the category that Jean just mentioned, not only talking about what's the sustainability plan, but at some point, not on the table today, but maybe we need to talk about an evaluation plan as well. One of the things that I hear about as I move around the state is we're trying a lot of things, and in some cases we still don't have the research to understand does approach A work or not work. I think we're probably still too early to be able to do that, but at some point, learning, especially around care coordination and interventions that work or don't work, there may be an important role for evaluation down the road.
Yeah, formal evaluation, but also sort of continuous learning and mid-course corrections and that sort of stuff. Yeah, okay, all well taken. Thank you. Are there any other general points? We may have exhausted the number, but if we haven't, any other kind of themes? Okay, again, please.
In 2 places in the executive summary, the phrase phrase integration of staff was used, and I know the intent. I was just concerned that that might be misunderstood by people when you talk about integration of staff at hospitals and long-term care and this and that.
Yes.
Striking there, so you might.
Well, you're absolutely right, and interestingly, Joanne pounced on that too. She got me on that. So if the both of you are concerned about that, that's enough for me.
Well received.
Yes.
So I sort of like what Carmela said about evaluation, but I think it should be paired with the very comprehensive evaluation that CMS would be undertaking. It's probably not addressing some of the same issues. These things are really expensive to be able to put a formal evaluation together, and a combination of various new evaluation type methodologies. The term of art is CMS shows rounding, tracking cycle,
Yeah.
which I think is not really sort of faster than one cycle, but it's still really slow. And in terms of sort of operationally turning results into something that can pivot, make mid-course changes before the starship crashes, is what the type of evaluation we really need to focus on with care management to get results out quickly, to make changes before a nice, very scientific, rigorous evaluation 5 years after we've all completed the project. It's not going to help.
After it's published in JAMA.
Yeah. And I think that's sort of where we got to really focus a bit of energy, but recognize that cost is a big constraint on it.
But we're again talking about work that's not what we are recommending. So the care, we can evaluate whether or not the work that we've recommended is doing anything. I.e., we connect 4,000 groups. But the evaluation, I would think, you'd pull into your regional grant process. Not necessarily.
Right. So I mean, we haven't really, it would take a book to write about the regional process, and so we were trying to stay out a fairly high level out of the book here, because we actually haven't we haven't talked that much about regional care planning in these meetings. We've touched the surface of it, but we really haven't gotten into the regional and local execution very much, and so the evaluation here would have to focus on the things that are being recommended. So,
And then just to that last point, I don't know if the title is the right title.
Oh, it's not.
Okay.
I wrote it and...
I was being polite.
No, don't be polite. I wrote it and I asked somebody, I said something like, this title sucks, please. and I did not get a better offer from my colleagues. So it needs a lot of work. It's too long, it rambles. It's like every other first title that I do. So anybody has a suggestion, please.
I think it also implies that we are tackling the entire universe when
Yeah.
we're only attacking a piece of it. And folks will be disappointed if they think that this paper is all the answers to care coordination and care management.
Yes, I know. People that worked for me for 20 years say never let him hear a title. They just weren't around for this one. But we'll get a better one. Thank you, Patty. Are there any specific wording changes? I know that you probably didn't read it as a copy editor. You read it as a thoughtful reviewer. But yeah, if you can also, if it's easier, you can scan and email those to us. We don't have to take a lot of time going through line and line. I just want you to know if you caught things and scribbled something, or if you were track changing on your laptop using the tracking feature, you can email those. Let me give you a suggestion on that if you do that. I'm going to be away for the next few days, then back in my office Monday morning. You can go ahead and email me. I'll be checking email once a day or something, but I'm not going to be working. A little mini vacation. So if you would copy my colleague Chad Perman, who's sitting there in the back, who's attended just about every meeting, it's cperman, P-E-R-M-A-N, at healthmanagement.com. So just like I'm Jay Meyer at Health Management. Just copy Chad, because he's going to be helping me, particularly in the next few days when I'm out of the flow, keeping track of something. So if you decide to send in a few edits, do it soon if you can. Let me just tell you what the process is, because Donna has needs for time. she is a woman on a mission, and her commission is meeting the 15th of April.
Yeah, and we have to dial for dollars, too.
You have to dial for dollars. She has a lot of needs. So, so here's what I'm going to try to do, if possible. It'll require good hard work on our end, but also some help from you. When I get back in the office Monday, and I'm going to be starting on this tomorrow and then out of commission for a few days, with the help of my colleagues, and I'll also consult with Greg and Deb Gracie on this, any thoughts that they've captured from today, and because they have contributed, as I've mentioned in earlier meetings, to the grid, the draft, everything. We work as a team, and so we will attempt to get to Donna for her and Alice for their quick review by, say, Tuesday evening or Wednesday morning at the latest, hopefully, a draft that captures all these thoughts. Maybe I'm going to be realistic and say Wednesday of next week, which is the 9th already. And then hopefully they'll take a quick look at it and, make some adjustments, which will always be helpful. And then we're going to get it out to you for a quick look that really, like, did he capture this? Or did they capture this? And at that point, I would kind of ask you to do track changes if possible, or, skim it, or send a quick note, but not, to the extent possible, rather than raising a lot of questions, because it would be hard for us to do that and meet Donna's timetable. Just go ahead and say, I would add this paragraph. Here it is, type it in, or this wording makes me uncomfortable. I've reworded it for you, Jack, or I've added something that I think you still didn't get. And that's what I meant by a quick look. We'll say as we mail it out, can you get this in 48 hours to us? You may or may not have time. I realize all of you have day and night jobs that have nothing to do with reading our draft. So just do the best you can. We'll give you as long as we can and still be able to then synthesize in your final edits and get it to Donna in time prior to her commission meeting. So I apologize in advance. That'll be short. And you can send a note saying, I'd love to read this, but I just don't have time on, go ahead without me or what have you. Or you could ask somebody on your team to read it, and so on, but just ask them to be very specific at that point. And that might include, take this paragraph out, I hate it, or something like that. But those kind of, or, just little edits. Does that make sense? I mean, I'm just trying to juggle a lot of things here. Patty?
So I don't want to, it feels like you're ending. You're getting to an end point, so I don't want to open up another can of worms. But I do wonder, again, the point that we keep making, we have gone so far, and we have acknowledged that. And we're not talking about a white paper that is the rest of it, right? But care management, care plans.
Yeah.
But yet the paper is setting forth a vision that would take to go there. You talk about social determinants of health, care coordination, talk about other models. And I think it would be appropriate to just ask the question, should we do that?
Okay. Let's discuss that. There are a couple of options. It's certainly not too late to phrase that. One thing that could be handled through careful editing, and we didn't do that in this draft, is to be more clear about this is our to-do list, that we are comfortable with making very specific recommendations, A, B, C, D. And yet we and that takes 5 or 8 pages, but not 20. Okay. Yet we recognize that this isn't the end of the game. That this will build the public goods, the common infrastructure, the data acquisition, using the data you have, the formation of the shareable profiles, et cetera, and that's mainly what we consider to be within our purview for this activity, as opposed to reinventing the delivery of healthcare and being much more comprehensive, and all that. That said, page 8 ends, the next section lays out our understanding of things yet to be done to really make care coordination and management work. That would include behavioral health integration, that would include addressing the factors outside the medical model and the kind of things that Ernest was talking about, but sharpening up that you're not making specific recommendations about that in the same way as you're making specific recommendations. Is that going in the right direction?
I mean, that's another option.
Yeah.
I think we kind of already said we should do that, right? Because we want to be clear that this is what this work group has recommended.
Yeah.
And I'm really asking it rhetorically because I don't know how I feel about it. But as a committee of, are we a committee of the HSCRC?
We're multi-stakeholder.
But paper feels like a policy paper.
Yeah, that's my fault.
So if you were to read it, you would say that the state is going in the state of Maryland is going in the direction of encouraging individuals to be in medical homes and then high-cost users to be in care management. I mean, that's what it says. And are we prepared to say that? We may be, each of us, but is the multi-stakeholder organization prepared to state that that's the state policy that we're going to now plan around?
Well,
I just feel like you have to be thoughtful about that.
Yeah, I'm going to see in a second who else would like to comment on that. I think what I'm saying is, what I'm suggesting is not that you're saying this should be state policy or we are declaring that this is state policy. That's not what I hope to convey. Is our recommendation as a working group is that, having said the specific agenda, that these things would be good to work on in the next phase of work. Ultimate success in improving the health of the population is going to require more than acquiring the Medicare data and building the care profiles. A couple of these. You got to use the care profiles. You got to form care plans. You got to better manage high-risk patients. You got to address all these other factors. I don't want to twist your arm to go there, but I think my understanding of this group is to give your best advice to Donna and her commissioners, who will see this report. This is our best advice. You do with it what you want. So let me get to, because you've raised this as an important point, Patty. Let me hear how others feel about it.
I'll jump in. I think Patty makes an important point. I'm trying to figure out, can we resolve it in an introduction, which reminds everyone who we are, maybe who we aren't. And to me, it ties into, maybe it's a very careful edit. It ties into some of the language in here, the we must, we will, this shall, which has, it makes it sound, and because ultimately it will be an HSCRC document, maybe the combination of those two things comes back to, this is a group of incredibly thoughtful people who we've brought together to provide guidance and advice to the rate setting commission, and to maybe couching some of the must-shall.
Yeah, sure.
And I don't know. Let's really think about it, because the HSCRC has actually said, relative to care coordination, we really don't have any regulatory authority over care coordination, but we are doing this with other state agencies and MHA to convene people to discuss how we could support the organizations in the state under the new model. So we're not doing this as a regulatory activity, but as a convening organization. So, we need to make sure that the ultimate, partnership activity and not as a policy of the HSCRC. It's for the good of the hospitals implementing the policy. It's for the good of the patients. It's for the good of the physicians who are trying to work with the new models, and so not as a regulatory tool of the HSCRC. So I do want to make sure we don't somehow flip that, because we've had that conversation a few times here, and I want to make sure that that is what's staying there, that this is not HSCRC policy. This is us trying to support the organizations in the state in doing the good job that they need to do. There are some pieces that were in the application, though. For example, the application to CMS did talk about having Marylanders in medical homes. So that's not a new concept or a policy that was set forth in the application. That's, you know, I think that's something that you can state that has already been put in front of CMS and in front of the hospitals and in front of the doctors when the application went in. Yeah, and in terms of dialing, I will tell you, in my pre-editing, I've already tried to dial back exactly what we're saying we're going to do at the end of care management, because I personally believe that we need to focus on care integration and ultimately build a lot of things into the approaches that are being used as opposed to thinking that we can manage them in. So we've tried to dial that back. I mean, Western Maryland builds a lot into their nursing home relationships, and there's not a case manager for every patient, but there's a process of care integration that's going on, for example. So we did try to dial that back a little bit so it wouldn't be, so that we're not hopefully coming off as saying, oh, we have 40,000 people, we have to case manage them. Because that would be a mistake to put that in here, I think. But we were trying to dial back and say, hey, we have 40,000 people that are high needs, and we need to figure out how to deliver more coordinated and integrated care for those 40,000 people. And it's not all going to be case management for sure. A lot of it's going to be care integration with long-term care providers or with mental health providers. It's not all about case managing. And so I agree we need to make sure that we are screech, stop short, don't state that particular endpoint. So I don't know if we've done a good enough job of pulling back and editing out, but that's what we tried to do. Lori.
I guess my question is, how does this group relate to, if it does at all, that next step, that step that we're identifying as a more regional approach, and some of the things you talked about in the sort of extraneous report that won't be included in this report, some of the things that are happening in the community that could benefit hospitals and benefit our efforts to make an impact in the long run. And I go back to, I guess, when we first convened, and one of my frustrations is coming from a community organization, being in the weeds, how do I get to let hospitals and others know in the behavioral health system, for instance, what's going on out there, what we can do to help you out, how can we contract with you, what can we do to help you manage these individuals who are a problem for you. And so I guess I have appreciated the discussion at the 30,000-foot level, but I'm wondering how that now connects with the weeds where I'm stuck.
Maybe just one thought on that, and perhaps I can use an example. Nicole knows much more about this. You know, over the last year, we have begun working very closely with the skilled nursing facilities through their association. We're about to co-sponsor, an activity together that brings nursing home leaders, hospital leaders together exactly to have these kinds of conversations. I don't know, and this goes to our earlier conversation, all of this doesn't have to be in the purview of the HSCRC, so perhaps some of the next steps are, you know, our organizations coming together and bringing leaders together and understanding, learning from these models, what are the various models out there. I thought the things that were included in the letter that was provided were very helpful. How do we help people with those to understand what's available? And some of that I think we can just do organization to organization.
That was great, because I think ultimately the success at that level is going to be the success of what this group has done. But I didn't want to lose sight of that, trying to figure out how to do that.
To me, it goes back to there's a huge amount of work to do to make this work, and this is just one small piece of it.
And I think part of the regional planning process, we're hopeful to have some exchange going back and forth to understand where people want us involved or want MHA involved or some other resource involved as opposed to we really don't need to be involved in and it'll be taken care of in some other way. So we would hope that there would be conversations and even discussions among the regions as they're doing their planning processes and try to create some feedback loops out of that process as well to help us see how we can work together or not.
Okay, yeah.
Just one clarification on the timeline that you put out there, Jack. Can you maybe pinpoint the day or two that people should expect this and maybe even set aside some time to be able to look at it? You mentioned that Donna and team will be getting this on April the 9th. And just wondering if it's Thursday.
No, let me back that up. The 8th.
On the 8th.
Yeah,
Okay.
no later than the 8th. I'm lashing myself to the mast on this because I'm going to be away for a few days, but we'll crash on it. And then so let's say, they're busy too. We're all busy. But let's say Donna and Alice are able to look at it and go through it, and they can also be reading it while you all are reading it. But I want them to review it first and see if because they're helpful on this. You missed this, or you really need to change that before it goes out. But then they can also be reading it in the next few days too. So we'll work that out. So let's figure, I'm glad you brought that up, that fingers crossed, it goes out, say, the close of business the 9th. That's kind of not easy because it's going into a weekend and so on. Then I think you need this completed before your meeting, your commission meeting, right? Or do you need this in hand?
Well, we definitely need a good draft. We can actually continue to work on it after the meeting, so I don't want to, but
it's a public document at that point?
Public now.
It's already public now, so we can continue to tweak it after the commission meeting. We need the recommendations to take into the commission, and we need a draft document, and we need a presentation for the commission. So.
I think it pretty much has to be. It has to be.
Yeah,
really
it has
solid.
to be.
Yeah,
It has to be. We would really want it to be as final as possible.
Okay, that's my thought.
We don't
So,
to
to pick up on Carmela's good point, because I'd be the same way if I was in your shoes. When are we going to see this, and how long do we have? Because you all are busy. So assume you're going to see it around the 9th, which is a week from tomorrow, right?
Right.
Yes. Thursday. A week from tomorrow. Yeah, that's right. Then I would probably say try, if all possible, to get any final comments by close of business the following Monday, the 13th. That puts a lot of pressure on, but again, if what you do, and you can say, I skimmed it, it looks okay, or here are a few comments, I'm hoping that you won't have major problems. If you do, you do, But if to the extent that you can suggest some specific wording changes at that point, I'd feel a lot more comfortable. Here are some track changes, or please take this sentence out. It really worries me. That kind of thing. If you can do that, I mean, heck, we can look at those and proof them and accept them in, and it's some synthesis involved because they'll be coming from several people, but we can do that. and turn it around in about 24 hours and have it. It's tight, but that's what you can kind of think of. So if you want to read it on that Friday or glance at it over the weekend or what have you, I'm sorry that the time is so tight, but that's what you could expect. Does that make sense? Okay, good. Then I think we're right on time to talk about next steps. We've sort of gotten that a little bit already. So let me suggest that I think we've talked about number 1. We've just finished that up. We sort of talked about number 3. That's up to Donna and the commissioners, but she may want Carmela or you and Laura or one of you to come and say a few words about the report or summarize it, or, that can be worked out, but some way, or she may not want that, but that should be discussed, If you need that, somebody could come and highlight the report. If you don't, fine, if you have it in hand. So we really want to talk about 2, 4, and 5, and anything else that we may be missing, which have to do with, kind of Jean's brought this up in a different context. Okay, we finish up. Now what? What's going to happen? What are how do we educate people about this important process? How does it relate to the regional planning grants that will be emerging? What's an action plan for a statewide campaign? That there are things in these materials that talk about a statewide campaign, as I recall in the grid, it's in there. So any thoughts you have in the next few minutes about next steps? You can play off what's there, but also maybe you have a totally different idea. We're going to finish up our work in a couple weeks. What would you think about, and this is our last meeting, what would you want to recommend? We might even work in half a page at the end of the report saying, the group feels you don't like that idea. Oh, you like it? Okay. Yeah. Okay. We might even work in a little to-do list or something like this next step. So the floor is open.
A question. Obviously, there were several other work groups also meeting, probably along a similar timeline. I'm not sure if their recommendations or advice have all been documented yet, but I know that there was data infrastructure, position alignment, community engagement. There were several. Is there anything that we're talking about here that you would expect there to be gaps? I mean, we spent so much time on data and infrastructure that there's a whole other group working on data and infrastructure. So curious in terms of the alignment of the group, anything or any concerns that we're going to have gaps in the collective recommendations. I just don't have eyes into those other work groups.
Well, the data and infrastructure work group preceded this. And they said, hey, you really need to get going on this. And so here we are, trying to get going on it. And so we're actually following up from that work group. The alignment work group is not meeting right now, but from a process standpoint, I mean, we are talking about alignment issues here when we're talking about the whole CCM fee, for example, and trying to build some of the alignment vehicles. So I think the alignment, we see the alignment work group starting back up after this because it will be hard to have alignment without infrastructure. So that's kind of, you can have alignment models, but if you have no infrastructure to actually connect people, it's kind of hard to get in alignment. So I think that is really the next step from here is to go back into, with the alignment work group to reconnect and make progress on that side. And we have been working with the consultants in the background. Medicaid has been focusing on getting some funding from CMS around dual eligibles, and so we have to, get back into with this information to bring it into that process, as opposed to having to coordinate with that process, that process will follow this one.
And then obviously we spent a lot of time on consent and the consumer engagement. Is that another parallel group, or am I not?
Yeah, actually the consumer engagement is a parallel group, and in a lot of the meetings they've been sitting here with them, listening to these meetings, but also they've been working in the separate processes.
Although maybe just one clarification, in a conversation with David Horrocks, I think the patient consent piece is a piece that he feels that they would need to bring people together. It's sort of getting that clear before we can build what it is we're talking about here, because we can't build it if we don't have the consent and the policy.
I just wanted to add about the consumer engagement and outreach work group. Lenny Preston did see a copy of the grid and provided some comments back to Jack, which I believe Jack's incorporating some of those into the report. So
yep, we definitely did. Thanks for reminding me, Steve, on that. We got Lenny's comments, and we are going to be building them in. Any other thoughts about next steps?
Maybe there are a couple that are just obvious from here. I think there are. It sounds as if there are potentially 2 RFPs that we would be requesting of Chris. One relates to the data infrastructure to identify high-risk patients. The second relates to the creation of the viewable care profiles, and those might be 2 separate things. The first one has multiple steps to it, including the consent piece. There's a second sort of to-do, which is, I think, rests with MHA, go out and make the special request for the data. I think that's an important next step. And there's a third piece, as I'm looking at what we've put on top priority, and relates to the conversation we just had. And that may just be something we can organize. How do we bring together, if we want to make BRFA funding available as we take a look at planning approaches for integrating somatic and behavioral health? How do we begin to pull people together around what the options are, what the new models are that might add some smarts to any sort of planning? Those are the 3 that I saw.
Yeah.
And Colonel, when you were saying about Chris and the things that included the care profile and stuff, does that also include the ability to see that who gets there, that individual who is coordinating the care, like we talked about before and a little bit today, would that be in that, or is that a separate consideration?
Someone else may. I know the answer to that better.
Identifying the care team as part of the care profile is what you're saying. I think that's been said as an important piece of that care profile.
That goes into the viewable part, I think.
Okay. I think we've reached, we have 2 things left to do. Your closing remarks, if any, and then allow session. Pardon?
I said we didn't talk about educational sessions.
Oh, right. Yes, I teed that up. I didn't get any takers, but how do you feel about some educational sessions?
Just to be clear, about sounds silly. About what? In the absence of saying care coordination.
Well, so I think, and you know, I've had some conversations with Patty, and you're bringing up there's strategy here that's involved in this whole document. So does it make sense to have broader discussions with the hospital organizations, the physician organizations, to say, hey, here's the strategy that we're thinking about, and that you all have contributed to. Here's the strategy that's been talked about, and this is why this strategy was talked about, and here's the underpinnings of the strategy, and what do you think about that? You know, just to kind of have a bigger discussion with the field about it.
And I think the question is perhaps how much of that is already going on. So, for example, we've been engaged over the last year in joint programming with Lifespan and HFAM We just did a program jointly with the emergency physicians. Amy Boutwell came in. It was about readmission reduction, patient handoffs. I'm thinking if we're talking about something on behavioral health, doesn't mean that there's not more. I'm just wondering, does this now begin to grow organically among the different stakeholders, or is there a broader role or umbrella?
I guess I had the impression that you were talking about the executive suite, partially, of making sure that the executive suite of the organizations were thinking the same thing, since they're holding the purse strings, and you know, is it a strategy that people are going to adopt?
Well, so I think it's an important question. I don't know exactly how to answer it, because, and I'll go back to Dr. Carter's point that was contested, which is he said hospitals aren't doing that, and yet hospitals are at some level doing that, whoever this is. So I think that there's not, from a hospital perspective, they don't, I'll speak for generally, not for my own hospital, but just generally. Hospitals don't traditionally do the kind of care coordination that is being referred to here.
Exactly.
They have been incentivized to do more and do the waiver, and they're trying to figure out if their role in this transition of care gains. They're worried, I think, that it's going to, all of this is going to somehow come out of the GBR somehow, which of course is obviously concerning for all the reasons that hospitals are trying to figure out how to manage within that current model. Payers are out and about creating these infrastructures, some of which work better than others, and don't necessarily create that patient view, right, in the form of payer. It's a payer-centric view. So I think that the general message is that the cost of the state has moved in this direction around the waiver is that we, from a policy perspective, support all of the efforts that so many people are involved in to better deliver health care and manage transitions, or however we characterize it. And that we are relieving that at the state level and the regional level. We can create, you know, some infrastructure to support that. But if we go too much further, the question people will always say is, well, what does this mean to me? And it's going to scare people, I think, if we're not, you know, openly kind of entertaining the dialogue. But I think you can go as far as you've gone, which is that it just makes sense, right? It just makes sense for a healthcare system to support the direction that is out in paper. And I wonder if there would be some value in having some, you know, through your process, the executive of the MHA, you know, say, yeah, we agree with that. We just don't want, you know, suddenly a public utility that we're supposed to buy into, right? Because they don't know what that looks like. So, I mean, I think it would be valuable to.
It's really difficult to make a prescription.
Yeah.
It really is, because of the unique characteristics of each region in the state.
And even pursuant to the regional concept, some people, I don't know if everybody's buying off on the regional concept. You'll find out where people are when you get the refund.
Well, this document says regional and local, so we haven't even gotten
So, I
to
mean, again, I think it's laudable that you have, through your approach, through your tried approach, MHA, HSCRC, and DHMH, to have started this conversation, because the waiver appropriately required it. But I think it's an iterative one. And so I would think that you might want to do a little communication strategy as well. And unfortunately, there aren't any payers here. You know, we're all providers and payers. But just like I don't believe their first John's been participating. So I don't know what the payer's reaction is.
Well, he's been on the committee, so I'm sure he supports everything we came up with. But I want to, on the education side, I kind of think it's different depending on who you're talking to. I think like Lori and Adrian might need a certain type of education around this. My physicians, I think it would be very helpful, and I'm willing to take the lead maybe with Craig on this with you, is working on educating our physicians around this, but particularly around those care management codes. And I think that's something that we need to do, and I think it's important for my members, no matter where they work, whether they work for one of the entities sitting around the room or whether they work independently. So that's something I think on the educational front that we would all agree needs to be done. I think it's appropriate for MEDCAD to take the lead on it. We're willing to do it. And we are trying to get in some of these regional proposals that in as part of it, but we're also willing to do it directly with you. However you think it should be done, because we think that's important and that's part of this and it helps everybody. So on that front. But I do think that education is going to be a little different depending on which segment of this table you're talking to.
Sounds like it's like education as well as kind of like buy-in, you know, like or assessing or whether there is buy-in on some of this. I mean, your point is valid about the payers not being at the table without payer buy-in on a lot of this stuff.
I mean, it's a logical extension of the waiver conversation that you have to otherwise continue to have.
And I wrote down, I don't know that it's an educational session as much as we're talking about convening leadership dialogue. And it's talking about this issue and continuing to talk about it and learn about it, but the conversation that Gene may need to do with his members may be a different conversation.
And I think ours is to every average member. I think ours is maybe a little different than some of the others here. We're a different deal, but I think it's really important because each individual decision has to make each individual physician has to make the decision, you know, is she going to that day build his care management code? Is she going to take advantage of it? Is she going to, and that's the discussion. We need to find out, are you aware of it, number one? Then number two, if you're aware of it, why are you doing it or not doing it? And then are there any barriers? And then how do we resolve those? And so that's in my mind, our part of the education is really important. And obviously certain specialties are more effective than others, but that's where I think we fit in and where it's important for us. And that would be something we're very willing to do and take the lead on.
I think that's where the ROI conversation comes in. And when we talk about why is this valuable, why is Mid-Atlantic Permanente Medical Group as a state, I obviously cannot speak for the health plan, but we have done a lot of work and invested a lot of effort internally on readmissions and care coordination, but we recognize that we cannot do it in isolation, and there's a whole world outside of our health system that we do not control. And so by us working together, it benefits everyone, and that's why the medical system is here.
Thank you. Good. Howard.
I agree with what everyone said, and the communication, I think, is critically important because unless, for the vast majority of people, unless you've been at the sharp end of this state, the lack of communication, they don't even know that it's a problem. So being able to reveal it to people, but with a succinct message that's clear, not so that it's hazy or vague, so that it's not misunderstood, is also critical. You know, a lot of people giving a lot of different messages can be very confusing to everyone. I think the message is really the core of the message is reasonable to just slow down. And overall improving healthcare.
Yeah. And I think back to a point Adrian raised a little while ago, it would be important to have the patient's voice in these educational sessions. Just, you know, using the example, I have a nice relationship with my provider. I get in crisis now and then. I trust this person. What are you doing to me? Having some reality therapy from the world of patients and consumers, and this is what I need. And it may not be that, but this is what I need, you know, would be helpful.
So ONC put together this Blue Button initiative, truly launched very well. But they have some wonderful public service announcements associated with that. It's just exactly what you're talking about.
Oh, good.
It's people talking about how lack of care coordination has hurt them, and how communicating across those continuum has really helped. And I think it's wanting to distill it down to a simple message, and everybody can understand it. It's worth thinking about.
Yeah, thank you. I wasn't aware of that.
I don't want to overstate this.
Go ahead.
But those of us that sit at the CRISP board, and David Hart is very good at this, are we remind ourselves that we are here to do that which collaboration is the best methodology. So we would constantly ask ourselves that question. Is collaboration the way to do this, or is it better done separately or through competitive methodology? And that is a in some ways reflective of what the state has done for 40 years around hospital rate. You know, it's just what the pushing it and then saying, well, there are other things that we can do through collaboration that allow us all to meet our mission. And you know, I can just say, I walked out of here. I walked out of Ron Peterson's office to come here, and that's exactly what he said. Is I would prefer a collaborative model if we can get there, because it helps me meet my mission, our mission. And so I think if that's the conversation that we're having and we're furthering it, I think that people will get that. And then they'll just want to know what the execution strategy is, knowing that each step you take, you may want to continue to check yourself, which is what we do, Mark and Chris, pretty regularly. And it's working pretty well, and it's with, you know, competitors.
That's good. Thank you. That's very helpful. And I'm going to try to capture that in the redrafting, tighten it, put it right up front.
I want to put a plug in for public health, because one of the reasons I think Chris works well is because public health is integrated. I think at the center of care coordination is public health. And I think the integration of public health with the healthcare system helps that collaborative effort. Because when I go to talk to one hospital, MedStar, or I talk to Dimensions, or I talk to doctors, they treat me as this amorphous entity that says, I want to work with you. So MedStar will say, yes, I'll do this, and then Dimensions will say, yes, I'll do that. But then when doctors and Dimensions decide that they want to talk to MedStar, no, I want to do this in Baltimore. We got more. It's a different thing going on. It's helpful to have this public health centric sort of model, because public health, our interest is in the helping to change the health outcomes of the public. And so everybody's interests that are around that we have to deal with when we're doing care. When you're doing care coordination, you have to deal with everybody. We got the hospital, we got the FQACs, we got the private doctors, we got everybody in the room, plus our people from police and EMS. And in that, you've got to get everybody to talk. We've got to get people to talk to our behavioral health people. You know,
they're all seeing the same page.
Yeah, you know, we got to figure out, okay, how is this actually going to work? So I'm putting a plug for public health. I believe that in the center of whatever's happening with the state at the state level, Laura has to be in that role, and she is. I'm just saying, but I'm just saying that the infrastructure is built on public health infrastructure, and Chris serves public health. I mean, for me, Chris is a solid infrastructure in public health, and we can leverage a lot of technology through Chris, because Chris' goal is to be the health information technology for public health.
Good. Thank you. Thank you for the reminder. Not to let that. I need it. No, but it's important. You know, and but not just the reminder, but that it's not just something sitting over here. Oh yes, public health.
Right. Yeah, not oh yes, public health.
Because that's what people do. They park it over here.
They'll park me over here.
Yeah.
You notice I don't like to be parked.
I noticed that, and I'm trying to pull you into the building and get you out of the parking lot. So thank you. Any last comment before we turn to public comment? Okay. It is now time. We have a few guests. Yes. Come up to the table. You joined us before and have been so helpful.
Sit next to Pat.
Amy, right?
Who will protect me.
Yes.
Just a couple.
Could we get Amy a chair?
No, I don't need a chair. I'm fine.
Amy, you don't have
be
to
able
kneel.
to get up. Thank you.
Good.
Thank you. Just a couple of things that I've been talking to Nicole Stallings and others about as we've reviewed this document. Whether intended or not, our feeling is that the patient is woefully missing in terms of partnership in this document. Whatever plans of care providers create have to be in partnership with patients. And our experience over the last 3 years, and we have lots of it, is that you can do all the chronic conditions and identify patients that you think are at risk, but in fact it is the patients at risk who have significant values, beliefs, and preferences that have to be engaged. And without that at the outset, regardless of what we do and what layering on of data and who we identify, which can sound very paternalistic, we have to engage the patient. And when you look at the chronic care management documents from CMS related to how to engage providers in that particular reimbursement, there are very specific things that provider must do in order to recoup that reimbursement. And it is not insignificant. So if you want to know why the providers aren't doing it, they need significant infrastructure in their practices to do it. They have to have structured data recording, which is some of the work that you're discussing. They have to have a very prescriptive care plan, which is shared and conceived with the patient. They have to have access to care that is 24 hours a day, 7 days a week, as well as opportunities for patients to communicate with their providers 24/7 through other texting and other kinds of messaging. Many providers do that now, but many cannot do it. They're not reimbursed for being on call 24/7 for that. That's just not how physicians are paid. So you need to understand the significant infrastructure. But one of the things that's really important in this document, when it talks about the chronic care management, okay, so this is the MLN, so it comes from CMS discussing the chronic care management services that I believe everybody is interested in. But the patient agreement requirements is most telling, and this is the piece that I believe has to be part of this document in order for us to move forward in any way. One, that there is patient consent, and these consent requirements, and this is for that billing code, inform the patient of the availability of the CCM service, the chronic care management, and obtain written agreement to have the services provided, including the authorization for the electronic communication of medical information with other treating practitioners and providers. That's number one. So that communication of health information and PHI has to happen with patient consent according to the CMS guidelines. It is not an opt-out. It is an opt-in. And I think we have to really be thinking about that if we're really going to turn the curve of caring for our highest risk patients in Maryland. So I just wanted to bring that up. The other elements of this is that the patient has to be offered the care management service. It has to be documented in the medical record. The care plan that's developed is done with the patient, and the patient has to be told how to revoke that service. So if they don't want it anymore, they have the right to not do it. So I think these need to be considered as you move forward with this document.
Okay, thank you. That's a very important reminder. Appreciate it. We will pay heed to that. Thank you, Amy. Anyone else? Yes. Welcome back.
I don't think I've missed the meeting. I don't know.
No, you haven't. You've been wonderful in your attendance.
I really want to applaud you guys. I actually really do.
Can you?
My name is Jim McGee, M-C-G-E.
Can you repeat that?
Yeah, M-C-G-E-E. Let me pull this out here so I can talk more comfortably. And I am the Executive Director of the Trans Employees Health and Welfare Fund. And as I think I explained last time I was here, that we've been kind of dealing with this issue for quite a long time. And really struggling with some of the same issues that you're doing, which is twofold, how to get the data to know who we want to engage, and dealing with how to engage people. And so I really want to applaud your efforts, and I don't think, well, maybe Carmela and some others appreciate what other people in other states think of this effort when you describe it to them, because it's really atypical of what's happening in other states. But I want to also say that, just kind of speaking to the last point, this is not about how to do care coordination or how to do care management. It's really kind of how to facilitate, how to support the process. And I appreciate the notions of collaboration that have been expressed here, which is really rare. And the last point I want to make is I don't want to see hospital rates go up.
Thank you, Jim. Appreciate your regular attendance and talk at the last meeting and joining us again and speaking at this meeting. I think, Madam Chair, that does it.
Can you ask you to have your lunch tomorrow?
It's turning into dinner.
It is. If I could just, a few words of closing, because I think this will mark our last formal gathering. There's more that we'll do together. I just want to say on behalf of Laura and on behalf of myself, thank you so much. You've participated in groups like this before. This is a group with a wide variety of views and opinions. The great news, not a shrinking violet among us. And I just want to say thank you. We were given a very challenging task, care coordination. And I believe that we have put our arms around it, squeezed it into something that can be a very important next step for us in the state of Maryland as we're trying, as Jim has just said so eloquently, to go where no man has gone before from a state perspective, and that does require collaboration. Collaboration is very, very difficult to do, and I think we've got a number of examples where we've done it well in the state, and the opportunity is just there before us. So if I may, on behalf of Laura, on behalf of me, thank you for your personal investment over the last few months. Greatly appreciated. And thank you.
Thank you.
And thanks to Jack, as always. With that, we are adjourned. Thank you. Yeah, there are no